welcome again, everyone. For those of you that have joined in for the other presentations today, welcome again. And this is our last presentation for day one. So I'd now like to introduce, some of you will already know him, but for those of you that have not been to any of our conferences before, Dr. Fumihiko Urano from Washington University Hospital in St. Louis. And he's going to give us his presentation on his latest research. And I'm sorry, Fumi, but I forgot what the title is. Too many things. So I'll let you take it away.
Okay. Hi, everyone. How are you? Buonasera. Guten Tag. Como esta? I don't know which countries are you from. But, thank you for attending my talk. And Tracy, thank you for inviting me. And thank you for giving me an opportunity to present my work on Wolfram syndrome. So it's always great to see my friends in UK. I hope I can see you in person next year. But I really appreciate Tracy, Paul's efforts to, host this meeting. So let me share the screen. Can you see my screen? Okay, so the title of my talk today is Novel Therapies for Wolfram Syndrome. I am Fumihiko Urano from Washington University School of Medicine in the United States, and I'm a professor of medicine and attending physician at Center for Advanced Medicine there. So here is my disclosure, just in case I have some patents related to my talk today. And also I will discuss a little bit about the off-label use of two medications, dantrolene sodium liraglutide. And I know right now there are 4 Premier League games ongoing. So this is there, I think right now, halftime. So Arsenal, Liverpool are leading. And Manchester City, it's 0-0 right now. Okay. Anyway, you can watch it after my talk. And before I move on, I'd like to thank all of my collaborators at Washington University and in the world. Clearly, people in my lab, Dr. Halsey's lab, Dr. Marshall, and also Dr. Barrett, and support and funding from multiple patient organizations, Snow Foundation, Silverman Fund, Ellie White Foundation, and Rebel Syndrome, and Stowe Fund, I Hope Foundation, Faywalk Fund, the Wolfram Syndrome Foundation in Italy, Spain, France, and Wolfram Syndrome UK. So thank you for your support. Okay, so before I tell you about our therapeutic development for Wolfram syndrome, I'd like to remind you that Wolfram syndrome is a spectrum of disorder. As many of you are probably aware, some patients with Wolfram have mild manifestations, and some patients with Wolfram have very severe manifestations. And there are multiple reasons that some people have severe manifestations and some people have mild manifestations. And it seems like the types of mutations patients have somewhat determine the severity of the disease. So I have some idea. So what I'd like to tell you is that if you find, or if your child has been found to have mutations in the Wolfram gene, don't think that your child's life expectancy is 35 years old, because that's not true. So it really depends on a type of mutations that patients have. So don't think that. So it's very important. And I would gladly discuss this topic maybe next time. But I'd like to remind you that Wolfram syndrome is a spectrum of disorder. Some patients have mild manifestations, some patients have severe manifestations. And so we are developing different types of treatments for Wolfram syndrome. And as you know, Wolfram syndrome is a genetic disorder caused by pathogenic variants, mutations in the WFS1 gene. So here, root cause of the disease is mutations in the WFS1 gene. And then downstream is endoplasmic reticulum stress and cell death in different tissues, including insulin-producing pancreatic beta cells, retinal ganglion cells that can lead to optic nerve atrophy, and also neurodegeneration, especially brainstem and cerebellum. So there are three major points to target for the treatment of Wolfram syndrome. One is to target endoplasmic reticulum stress or endoplasmic reticulum homeostasis. And second could be to target mutant WFS1 protein produced from mutant WFS1 gene, or target their very upstream, target mutations in the Wolfram gene. So we are taking three different approaches, and we have already tested. So probably Dr. Barrett's the valproic acid falls into this category, the pharmacological compensation targeting endoplasmic reticulum stress. And so we have identified several medications or compounds that can target endoplasmic reticulum stress or endoplasmic reticulum homeostasis. And we have conducted a clinical trial using dantrolene sodium targeting endoplasmic reticulum calcium homeostasis. And we have conducted a trial. It's a phase 1b/2a clinical trial to assess the efficacy, to assess the safety of dantrolene sodium and the efficacy of dantrolene sodium. And it was an open label study. And we have published the results in a Journal of Clinical Investigation Insight. And you can download this article for free. So you can Google it and you can download it for free. In short, it was not the major success, but I learned a lot from this clinical trial. So now, based on the information we have learned from this trial, and based on the information that we have learned from Dr. Hersey's research clinic at Washington University, now we are planning to test AMX0035 for the treatment of Wolfram syndrome. So this medication, this is a new compound targeting mutant WFS1 protein. So it's also endoplasmic reticulum stress and mitochondrial dysfunction. So this is AMX0035 developed by Amylyx in Cambridge, Massachusetts, not Cambridge in England, Cambridge in Massachusetts in the United States. It's a mixture of sodium phenylbutyrate and taurursodiol. And sodium phenylbutyrate has been shown to reduce endoplasmic reticulum stress. And also taurursodiol, it's also, people call it thickr. Thickr you can actually purchase, it in the over the counter, but both thickr and PBA target endoplasmic reticulum stress. And in the case of thickr, it also mitigates, it improves the mitochondrial functions. So these two are interesting compounds, and Amylyx mixed these two compounds for the treatment of neurodegenerative disease called ALS, amyotrophic lateral sclerosis. But we have realized that this compound could be beneficial for patients with Wolfram. This was actually suggested by one of my friends, Dr. Sarah Gladstone. And so through then, the Amylyx talked with Dr. Gladstone and the Eddie White Foundation, Snow Foundation. Then we started collaboration with Amylyx. So what we did was we tested AMX0035 in neural progenitor cells derived from Wolfram syndrome iPSCs. iPSC stands for induced pluripotent stem cells. So induced pluripotent stem cells can differentiate into any types of cells, including brain cells, insulin-producing cells, and also retinal ganglion cells. So we collected blood samples from our patients. Then we created iPSCs from these blood cells. There's a technology to do it. Then we differentiated induced pluripotent stem cells derived from our patients into neural progenitor cells. Neural progenitor cells are brain-like cells in the dish. Then we, so it takes around 15 days to make neural progenitor cells from our iPSC cells. And then we treated neural progenitor cells derived from Wolfram patients with this compound AMX0035. And as you can see, so we looked at their cell death in these cells. So Caspase-37 means cells are dying. So y-axis shows cell death. So the high number means cells are dying. So then we treat, BICR means no treatment. When we treated this patient's neural progenitor cells with AMX, we could reduce their cell death. And the PBA and thickr are components of AMX. So we tested AMX0035 in 3 lines from 3 different patients, and we got their consistent results. We could consistently reduce cell death. We also looked at mitochondrial functions. As you may know, Wolfram cells have, cells from patients with Wolfram have a little lower levels of mitochondrial functions. Mitochondria is important for making energy in our cells, and it's connected to endoplasmic reticulum. So by treating cells, neural progenitor cells derived from Wolfram patients' iPSCs with AMX0035, we could improve mitochondrial function. So these results were encouraging. So we created pancreatic beta cells, insulin-producing cells from iPSCs of Wolfram patients. So it takes probably 35 days to 6, 7, 12, 19, 28. Okay, around 30 days to make insulin-producing cells from iPSCs. And we have a very good protocol to do it. And then we have created pancreatic beta cells, and then we treated these cells with the AMX0035. So by treating these cells with AMX, we could improve insulin production in these cells. So blue is without treatment, and red is with after the treatment. And y-axis shows insulin production, insulin secretion. And this number is glucose. So when we give higher levels of glucose, these cells produce more insulin. And by treating these cells derived from patients with AMX, we could improve insulin production in 2 independent cell lines. We also treated Wolfram mice with AMX0035 for 4 weeks. So blue is the Wolfram mice without any treatment. Pink or red is Wolfram mice treated with AMX, and green is control normal mice. So by treating Wolfram mice with AMX, we could reduce blood glucose levels. So y-axis shows blood glucose. So clearly, this is an assay called IPGTT assay. We could improve glucose tolerance. We could improve diabetes in Wolfram mice using AMX0035. What's interesting is blue is knockout Wolfram mice without treatment baseline. This is baseline. Then after 4 weeks, their diabetes exacerbated. But Wolfram mice treated with AMX, there is no progression of diabetes. So you don't see any difference between before the treatment and after the treatment. So that means this drug stops the progression of diabetes in the mouse model of Wolfram syndrome. We also looked at visual acuity, these mice. So Wolfram mice develops optic nerve atrophy, and they have low vision as compared to control mice. So y-axis shows visual acuity. It's not so easy to look at visual acuity in mice, so that the dynamic range is small. So the black is control mice visual acuity, and white is Wolfram mice visual acuity of Wolfram mice. So there is small difference. Then in between, these are Wolfram mice treated with AMX. Then this is after 4-week treatment, after 8-week treatment. Maybe there is some improvement, but it's not statistically significant. So we are repeating, we plan to repeat this experiment. We are running out of the compounds, but we plan to repeat this experiment. These results are sufficient to obtain the orphan drug designation of AMX0035 for the treatment of Wolfram syndrome from US FDA. So this was granted in October 2020. Then we created the clinical trial protocol for the treatment of Wolfram, and the trial protocol was submitted to the US FDA in May 2021, which was 4 months ago. And we received feedback from US FDA in July 2021, which was 2 months ago. So we are now revising the clinical trial protocol, and hopefully we can submit the investigational new drug application in the next several weeks. So currently we are working on the final trial protocol, and funding sources could be US NIH, FDA Rare Disease Grant Program, and Amylyx itself. So here is our clinical trial plan. So to assess the safety and the tolerability of AMX0035 compared to placebo-administered population. Also, we will determine the effect of AMX0035 on diabetes. More specifically, we will look at remaining beta cell functions in our patients using a mixed meal tolerance test. It's a type of glucose tolerance test. We will also look at their best corrected visual acuity and ventral pons volume and thalamus volume using MRI. So these outcome measures have been determined based on what we learned from Dr. Barrett's clinical trial in the UK and Dr. Hershey's research clinic in the United States, and based on the results of our dantrolene sodium trial in the United States. So we are still modifying the trial, and we plan to recruit 12 patients for the initial study. Then we plan to recruit additional 100 patients for this trial. And we, for the initial small scale study, we will probably conduct this in the United States at Washington University School of Medicine. And then when we recruit additional 100 patients, we may include other sites. And one of the potential sites is clearly England. And we contacted Dr. Barrett on this. And also 2 other sites in Europe have been considered. And so this is a developing project together with Amylyx in the United States. That's a biotech company. So that's our new medication. We are also developing gene therapy, regenerative therapy for Wolfram syndrome. So that is a major research project in our lab. And these are people in my lab, great people, and many of them are students. So I think we have 3 options for gene therapy. First option is to transfer normal WFS1 into cells lacking normal Wolfram gene. Eye cells, brain cells, pancreatic beta cells. Second option is to correct mutant WFS1 using gene editing or base editing. And I think there's a talk about this. And also the third option is to transfer regenerative gene into cells lacking normal WFS1 gene. So the second option, to correct mutant WFS1 by gene editing, we actually tested this approach for the treatment of diabetes in Wolfram syndrome. So we published this observation. So what we did was we created induced pluripotent stem cells from our patients. Then we differentiated them into pancreatic beta. I'm sorry. We corrected mutation in iPSCs using gene editing. Then we differentiated these cells into pancreatic beta cells. So this is very technical, but we corrected mutation by gene editing. So before gene editing, pancreatic beta cells derived from patients did not secrete enough amount of insulin. However, by correcting mutation, we could significantly improve insulin production. So y-axis shows insulin production. So gene editing really works in iPSC cells and also insulin producing cells. So we are trying to replicate this success in eye cells and brain cells right now. And to achieve this, we need models. So we are actually testing two preclinical models. So patient iPSC derived retinal organoids. We try to make eyes in the dish. And also we are using mouse and rat models. So this is very technical, but this is what we do in the laboratory. So we have iPSCs from patients. We differentiate them into retinal organoids using different types of compounds and growth factors and different types of media. It takes 84 days to make retinal organoids in the dish from iPSCs. So we try to replicate the differentiation process during the embryogenesis in the dish. And we have created a very good protocol. This is amazing work by Rie Asada in the lab. So it takes 84 days to make retinal ganglion cells, retinal organoids in the dish. And then after 84 days, they start maybe dying, but at 84 days, we have very good quality retinal ganglion cells. So retinal ganglion cell degeneration is seen in Wolfram patients, and then optic nerve atrophy occurs. So we are characterizing these retinal organoids. So they look like this. And so clearly we have Wolfram patients derived iPSCs, and also we have gene corrected iPSCs. So we are differentiating both lines. So we did gene correction, then we differentiated these cells into retinal organoids. They look like the same. So the top one is the retinal organoids from Wolfram patients, and these two bottom twos are retinal organoids from gene-corrected Wolfram patients' iPSCs. So this is very technical, and this is again technical, but we are looking at gene expression profiles in these retinal organoids, and clearly it's not their very homogeneous population. So we need to purify retinal ganglion cells from this population. So there is a way to do it. So single cell RNA sequence can identify retinal ganglion cells in the retinal organoids. So this is the analysis process, computer-based analysis process. And then we could identify the population of retinal ganglion cells in these retinal organoids. So what I'm telling you is we are purifying retinal ganglion cells derived from Wolfram syndrome iPSCs. And there is a good way to do it. So now we could purify retinal ganglion using this approach. We could purify retinal ganglion cells from derived from Wolfram patients iPSCs, and also retinal ganglion gene-corrected retinal ganglion cells from Wolfram patients. Then we looked at the viability of these cells. Without any stress, there is no difference between gene-corrected is blue after the CRISPR-Cas9 blue, red is before CRISPR-Cas9, Wolfram cells, Wolfram retinal ganglion cells. By giving some stress, the retinal ganglion cells derived from Wolfram patients are more susceptible to cell death as compared to gene-corrected retinal ganglion cells. So by correcting mutation, we could make retinal ganglion cells from patients with Wolfram more resistant to stress. We looked at different types of stress, glutamine stress, but this is really encouraging. So now we have a good model, dish model, to study optic nerve atrophy in Wolfram syndrome. So now we are testing gene therapy and different types of compounds in these cells. Also, we also have different types of rodent models of Wolfram syndrome. So as you know, in patients with Wolfram, there is ganglion cell layer thickness decreases. So this side, left side, control, right side, Wolfram patient. So ganglion cell layer thickness decreases in patients with Wolfram because then leading to optic nerve atrophy. And then also visual acuity is lower in patients with Wolfram. And so this has been replicated in Wolfram mice. So the y-axis shows visual acuity, and minus means Wolfram mice. So in Wolfram mice, the lower visual acuity is seen. So low vision. And the ganglion cell layer thickness also decreases in Wolfram mice. So these are the two outcome measures. So we always need outcome measures to test any new treatment. So when we do clinical trial, we need outcome measures. When we test new treatments, we need outcome measures in mice too. So there's a way to look at ganglion cell layer thickness in mice. It's called, this is a spider plot. It's a huge amount of work. But by using this, we could see the thinning of retinal ganglion cell layer in Wolfram mice. So these are outcome measures for us. So now we are testing two different types of gene therapy. We try to introduce a regenerative gene called MANF into retinal ganglion cell layer, and also WFS1 itself into retinal ganglion cell layer of Wolfram mice. So this is a gene therapy. And so what is MANF? MANF is a regenerative molecule. We all have this molecule. We all have MANF in our body. What we are trying to do, and this MANF gene confers protection against endoplasmic reticulum stress-mediated cell death. Also, it activates proliferation of endoplasmic reticulum stressed cells. So we try to enhance the function of this molecule by providing more MANF. So it's almost like liraglutide. We all have GLP-1 in our cells, but by using liraglutide, we can activate GLP-1 signaling more. So it's enhancing the GLP-1 signaling using liraglutide for diabetes treatment. So by providing MANF more, we can enhance the survival of endoplasmic reticulum stressed cells. So that's what we are trying to do. So we have been injecting MANF virus expressing MANF into eyes of Wolfram mice. We are using adeno-associated virus. So this approach has been utilized for the, making a vaccine for COVID-19 in the UK, as you know. So okay, so this is a very incredibly difficult experiment because mouse eyes are so small. So this is how we do in the lab. So we do intravitreal injection of virus expressing MANF into eyes of Wolfram mice. Then we are looking at retinal ganglion cell layer, thickness, and visual acuity. So what's interesting is so clearly MANF is high now after the injection of adeno-associated virus expressing MANF, we can see more MANF in ganglion cell layer. So red signal is MANF. So this side, there is no, we did not inject MANF. We injected a molecule called GFP, so we don't see any signal. But we see strong red signal on the left side, indicating that injection is working very well. Now we looked at ganglion cell layer thickness, and we could see an increase in ganglion cell layer thickness in the eyes injected with MANF, AAV MANF. So this is encouraging. We also looked at the histology of these eyes, and it seems like the MANF injection recruits cells involved in tissue repair. So this is kind of interesting. So we are working on this. And also we looked at visual acuity in these mice. So after the 2 months treatment, we looked at visual acuity of these mice. So clearly higher is better. So we got 2 different results. In males, we saw some improvement. In female, no difference. Actually, both of these not statistically significant. So what we are doing right now is we are increasing the number of animals to see if there is any statistical difference between these 2 groups. So we hope that these results will be positive, but we don't know yet. I think that's all I have. So it clearly takes a village to achieve a cure for Wolfram syndrome. We need support from patient organizations such as Wolfram UK, because then we can increase awareness of Wolfram syndrome, and the scientists can work together and doctors work together. And clinical service is very important. So I provide some clinical service in my clinic for patients with Wolfram syndrome and WFS1 related disorders. Philanthropies, grant funding are important. And then we all work together and to achieve a cure for Wolfram syndrome. Thank you.
Thank you, Fumi, so much. Really good presentation. It's really interesting to see what you're up to now. Obviously, we've read it on your updates that you've kindly provided that have gone in the newsletters and onto the website, but it's nice to actually hear it spoken about. So I've got 3 questions that have come in so far.
Okay.
So the first one is, if AMX treated WFS1 mice had a visual acuity significance of above 0.001 or less than 0.001. Does that make sense?
Yes, it makes sense. It makes sense. So yes, so that means that when we see the p-value lower than 0.05, we call it statistically significant. So statistically significant means we are sure that there is a difference between treatment group and non-treated group. So 0.11 means not statistically significant. So that means we are not so sure. So that's why we need to increase the number of animals. And also we may need to increase the duration of the treatment. So in short, we could see statistically significant improvement in diabetes in mice treated with AMX, but we did not see statistically significant improvement of visual acuity in mice treated with AMX. And there are two reasons. We may need more animals because the difference is small, or we may need to extend the duration of treatment. Based on my experience, and probably based on the experience of many scientists, it's much more challenging to improve visual acuity as compared to improve diabetes. But we are working on it.
Lovely, thank you. Next question. Has Amylyx found any significant side effects of AMX 0035?
Okay, that is a great question. So Amylyx did not find any significant side effects of AMX 0035, which is very, very important. The reason that's important is we probably need to treat our patients for a long period of time. So the challenge for me, challenge that I encountered in my dantrolene trial was that we could not push I could not push the dose. I wanted to increase the dose to see the effect, but because of the side effects, I could not push it. But because Amylyx compound has a much better safety profile, they can push the dose. So that is actually very important. So they did not see any significant side effects. And that was published in New England Journal of Medicine because they already did a trial in patients with ALS, amyotrophic lateral sclerosis, and the result was positive. So it was published and it's open to everyone.
Lovely, thank you. Is there any way to test for WS in utero?
Yes, there is a way to test WFS1 in utero. And so there is a technology called, actually many women who got pregnant before know that, amniocentesis. So by using amniocentesis, we can collect amniocytes from the baby. So the cells from baby is floating in the amnion. We collect these water, then we spin them down, we culture them in the dish, then we can look at WFS1 gene mutation. So we can test WFS1 in utero. We can also test WFS1 before so it's called pre-implantation genetic testing. And if we do in vitro fertilization, we can screen eggs or embryos that do not have Wolfram gene mutation in the dish, so that we can have embryos that do not have WFS1 gene mutations. So in short, we can test WFS1 in utero. We can also do it before implantation during the in vitro fertilization.
Lovely, thank you. There's another comment to say, amazing, very amazing. Congratulations on what you're doing. I have another question. The planned clinical trial with Amylyx will include adults only, is that correct? But wouldn't it be important to start modulation earlier in life, particularly in childhood?
Yes, that is a great question, and that's still under discussion. At this point, the Amylyx plans to do a trial in patients who are 17 or older. 17 or older. And so that's their plan. The reason is they don't have a safety data in children. According to Amylyx, because Wolfram is such a rare disease, it's possible to propose to include children, but that may delay the commencement of the trial. Because then, we need to, there are many things to discuss. So our plan is to start a trial in patients who are 17 or older, and then extend this trial in children. So they plan to do a safety study in children. So I think we should treat them earlier. So I think we should include children for this trial. I'm pushing it, but they are much more, I think they are very collaborative. They are great people, but they think that may delay the commencement of trial.
Lovely. And obviously we don't want to delay any start to any trials. A question, have you been involved in any evaluation of the liraglutide in WS patients?
So that's a great question. So yes, so I know few patients who have been prescribed with liraglutide. And so what I can tell you is that liraglutide is a diabetes drug. So initially, all the patients took less insulin. So insulin dose decreased. So, but we did not assess the visual acuity or neurodegeneration carefully in these people. So in short, insulin dose decreases after the liraglutide treatment, but then it may go up a little bit. It goes up a little bit. So that's what we have found.
Okay, wonderful. I've had a question. I'm just asking for clarification, but the question is, would it be okay to ask our neurologist to try this drug? Obviously, if it's not yet at trial, I suppose you can't ask your neurologist. I suppose you can't ask any medical person.
Yeah, okay. So the AMX0035 has not been approved by FDA or EMA. So no one can prescribe. No one can prescribe this drug. Liraglutide, dantrolene sodium, and valproic acid. Valproic acid and dantrolene sodium could be prescribed by neurologist, and liraglutide could be prescribed by an endocrinologist. But we should be careful.
Yeah, lovely. Patients in South America, could they be included in the trials?
That's a good question. So at the moment, I think there are 4 candidates medical centers for the AMX0035 trial, and I did not see a center in South America. I did suggest some centers in South America, but they want to make sure that medical center has enough experience to treat or examine patients with Wolfram. So 4 centers have been, okay. So there are 4 major candidate centers right now, and 1 in the US, 3 in Europe. And all the centers have significant experience in assessing Wolfram patients. And one of them is in the UK. Dr. Barrett, actually. As you can imagine.
It's the only one in the UK.
Yeah. So that's University of Birmingham Medical Center.
Yeah, well, that's wonderful, because I'm sure that many of our UK community would be keen to get involved as well. I assume that there will be eligibility criteria. You'll have to meet certain criteria to be able to take part in the trial.
Yes, so that's been also under discussion. So right now, the degree of diabetes, visual acuity, and some mental conditions, but it has not been finalized yet. So it's under discussion. I don't want to put strict inclusion criteria for this trial. And also, there are people who wants to be even more strict. There are people, who wants to be more lax. So that's actually a major topic of discussion right now. But I'd like to include as many people as possible.
That's fantastic. Yeah, I know there are lots of people that would obviously love to be involved, and obviously, like in the Treat Wolfram trial, they haven't been able to be involved because their vision's too affected. So yes, if it's going to be a wider population, I think that will be very encouraging news for everyone. Thank you very much. Most valuable insight in your research work. Excellent talk. We have another 2 questions come through on the chat. If AMX0035 is found to be safe and effective early on in the trial, could it be released for other WS patients?
The answer is, short answer is yes. That
Lovely.
has been discussed. Short answer is yes.
That's good. Regarding liraglutide, there was doubt cast on the long-term use affecting the pancreas. Could short-term use be helpful or intermittent be useful, or with other drugs?
That is a really good question. So the liraglutide may be effective initially, then maybe effectiveness may decline later on, but we don't know. And I think it all depends on the number of remaining beta cells of the patients and also other medical conditions that each patient has. So should we do intermittent treatment? Probably the person who asked this question is concerned about their beta cell fatigue, because if we push beta cells, they may get tired and they may eventually die. And so the answer to that question is that we don't know well. We don't know well.
Lovely, thank you. Another one's just come in. Regarding retinal organoids, how do you plan to use them as a drug screening platform?
Yes, so the retinal organoids can be utilized for testing the candidate compound. So the first screening should be done by a different method. So at the moment, I think it's very difficult to use retinal organoids for the high throughput screening. High throughput screening means to test 100,000 potential medications at the same time. It's called high throughput screening. And I don't think, well, it could be possible in the future, but right now, because of the complexity of making these cells and number of cells that we can obtain, and the duration of the time to make these cells, we cannot use these cells for high throughput screening. But once we identify maybe 20 to 50 compounds, then we can use these cells for that screening. So we can test maybe 20 to 50 compounds using this system, but we cannot use this system for high throughput screening. So high throughput screening should be done by a different method. So that's a very actually good question, and also technical question.
I have to say it does come from someone in the medical world. So.
Okay, yeah, okay. I can imagine. That's what I thought.
Lovely. Well, I haven't got any other questions pop up. So what I would suggest, and I'm sure you will agree, Fumi, is that if anyone thinks of any questions once we finish this presentation, or once they've re-watched the presentation, are we okay to use everything that you've spoken about? Fabulous.
Yes, absolutely.
Wonderful. So if I get any other questions come in from people rewatching or watching for the first time from the website, I'll send you the questions and then I can send the answers out to them. And what I might do, I think I did last year, I actually did a Word document next to the video. So it had other questions and the answers put there as well. So it just helps everyone.
Yeah, I would gladly answer any questions.
Lovely. Thank you so much. And
thank you.
I say nothing else has come on, so thank you for giving up your morning because it's morning over there, and I really do hope that we get to see you in person next year.
Yeah, I hope so too.